All right. Good afternoon, everyone, and welcome to this session on prescription for change, elevating the role of pharmacy in tobacco cessation. So my name is Richard Arndt. I am the Regional Pharmacy Director at Mayo Clinic Health System. So it's my pleasure to introduce this group of speakers here on my left. And this session engages pharmacy students, technicians, and pharmacists in understanding tobacco use and cessation. They'll compare the harms of different nicotine products, review the 5A's approach for tobacco screening and treatment, and discuss evidence-based therapy for tobacco dependence. You'll also learn valuable insights from community pharmacies, piloting the Ask, Advise, Refer model, plus how Wisconsin Medicaid supports and reimburses cessation services. The first of our presenters today is Rachel Schomburg. Rachel earned her BS and PharmD from the University of Wisconsin-Madison and completed a PGY1 residency at Wake Forest Baptist Medical Center. Board certified in pharmacotherapy. She practices at Gunderson Pharmacy and St. Clair Health Mission Pharmacy and serves on the PSW Community Pharmacy Advisory Committee and enjoys sewing, crafting, and family time. Joining Rachel is Alison Gorilla, MPH, an outreach specialist in the UW Center for Tobacco Research and Intervention, with over a decade of experience helping Wisconsin health systems implement evidence-based tobacco dependence treatment. She focuses on systemizing tobacco screening and treatment in settings serving populations disproportionately affected by tobacco-related health inequities, and holds an MPH from the University of Minnesota. Go Gophers. So, all right. A contributor to the content presented today, which would have been done by Matthew Letizia, but we have the DH over here, the designated hitter, is going to be Brian Bach. Brian is the clinical director at Hyatt Pharmacy, where he oversees clinical programs across 18 community pharmacies and a long-term care pharmacy in Southeast Wisconsin. With over a decade of experience, Brian is passionate about improving access to care through innovative services like disease management, vaccinations, and remote patient monitoring. He holds a PharmD from the University of Wisconsin-Madison and actively contributes to state professional organizations, including the Pharmacy Society of Wisconsin. Additional information about each of our speakers can be found in the PSW conference app, and please help me welcome our amazing presenters today. So, Rachel, all yours.
Is that a good spot? That's a good spot. Thank you, Richard, for that introduction. Allie and Brian and I are excited to be with you here today to share how we in pharmacies can advance provision of tobacco cessation services. We do want to also give a huge thanks to Matthew Letizia, who Richard mentioned was not able to be here today, but who contributed enormously to the content that we are able to share. Sadly, none of us have any financial relationships to disclose, but we will mention off-label investigational uses of the medications listed here for tobacco cessation. During our presentation today, we're going to compare the safety profiles of several nicotine-containing products. We'll review the 5A's framework that can be used all the way from screening for nicotine use through follow-up with people who are able to quit using these products. And then we'll apply that 5A's framework to show how both non-pharmacologic modalities as well as pharmacotherapy options can be used to help people quit. And then finally, we'll talk about how we can be paid for our tobacco cessation services through Wisconsin Medicaid. So Richard was kind enough to introduce us, but we also wanted to have an introduction to all of you. So if you work in a community pharmacy, would you be kind enough to raise your hand? Okay, a few. Do we have any AmCare team members here today? Yay, several of you as well. And how about any students? Excellent. And how about technicians? Yes. Oh, we have all the groups that I was hoping to see. No matter what your role or setting, there is a place for you in tobacco cessation services. So we are excited that you are here with us today. Before I jump too far into our topic, I want to highlight a few key resources. The first United States Surgeon General report relating to the dangers of smoking cigarettes was published in 1964. It noted that cigarette smoking caused lung cancer in men. There was not sufficient data to make the same claim for women at that time. Since then, there have been a total of 35 reports of the Surgeon General relating to tobacco use, with the most recent being published in 2024, discussing the disparities in tobacco-related death and disease. These citations are too lengthy to reference in full on subsequent slides, so for the remainder of the presentation, they're just referenced as reports of the Surgeon General with the year of publication. Smoking cigarettes is not healthy. Mic drop. End of presentation. We've known this for a long time. In addition to causing lung cancer in men, smoking cigarettes also causes lung cancer in women, at least 11 other kinds of cancer, cardio and cerebrovascular disease, COPD, rheumatoid arthritis, even reproductive dysfunction. Every organ system of the body is affected by tobacco use. Tobacco use and secondhand smoke cause nearly 500,000 deaths in the United States each year. Nearly 1 in 5 deaths. 1,300 people in the United States today will die because of the consequences of smoking cigarettes. Tobacco use is also financially costly, both in terms of direct medical as well as total economic costs. Tobacco cessation, on the other hand, reduces both the morbidity and the mortality associated with smoking. This graph shows the number of years of life gained by quitting on the x-axis compared to the age at which quitting occurs on the y-axis. For people who are able to quit by age 40, their risk of death associated with continued smoking is decreased by 90%. And even those who quit later in life can expect to have years of life added. The proportion of adults who smoke in the United States has decreased since that initial Surgeon General report in 1964. At the bottom of the slide along the x-axis, you can see the year, and then on the y-axis is the percentage of adults over age 18 who reported smoking cigarettes in the United States. The peak was at about 42% in 1965, and that decreased to about 11% as of 2022. But that's still more than 1 in 10 adults who continue to smoke. So why do people continue to smoke? Well, obviously because it's cool. The sentiment shared by Chandler Bing in the first season of Friends was ubiquitous in pop culture in the 90s, or for you young people in the audience, the late 1900s. Unfortunately, we're seeing a resurgence of smoking in pop culture today. A huge array of celebrities have been lighting up on stage, in music videos, in TV shows, movies, and in real life. Esther Zuckerman of the New York Times stated that the habit is no longer taboo. It's even being celebrated for the way it makes characters appear cool and powerful. Well, if people, especially young people, might start smoking due to cultural influences, including a desire to be cool, most people who chronically use nicotine products do so because of addiction. For our purposes, we are defining addiction as compulsive use of a substance without a medical purpose, despite negative consequences. There's great irony in people smoking to appear powerful, when in truth, addiction makes people feel powerless to control their thoughts and behaviors relating to a substance. Addiction is influenced by biological, psychological, and sociocultural factors. When we speak about the biology of addiction, we're typically thinking of addiction as a brain disease in which a substance, in this case nicotine, hijacks the brain's reward dopamine pathway. Twin and adoption studies provide evidence for a biological basis for addiction. Psychological factors that contribute to addiction include environmental cues and coping mechanisms. Smoking tends to become habitually linked to certain activities or environmental cues. For example, consistently smoking a cigarette with morning coffee or consistently smoking a cigarette while driving. Smoking can also serve as a coping mechanism in response to stress, loneliness, anger, or anxiety. Feelings of group belonging are an example of a sociocultural factor contributing to addiction, and particular social activities can also influence addiction. So what about other forms of nicotine? We know that traditional combustible cigarettes are terrible for our health, but we have a plethora of nicotine containing products available to us today. Let's consider whether electronic cigarettes or non combustible nicotine pouches might allow people to continue appearing cool and powerful without smoking cigarettes. As we were working on this presentation, Allie and I discovered that we are each conditioned to interacting with people who have extreme and opposing views regarding the safety or risks of e-cigarette use. Allie encounters many healthcare providers who think that e-cigarettes are just as bad as traditional combustible cigarettes. And I encounter many patients who think that they are completely safe. The truth lies somewhere between these extrema. And given the newness of e-cigarettes, their exact place on the continuum from deadly to safe is unknown. We're going to tag team the next part of this presentation to give you both sides of the argument so that you can decide how you'd like to frame conversations about this topic with your patients and colleagues.
All right, so we all probably have some familiarity with e-cigarettes. There are many different names for these devices: vapes, vape pens, tanks, pod mods, and the literature refers to them as electronic nicotine delivery systems. But they all have the same components: a battery that is the heating element that powers the heating element next to a cartridge that contains the liquid, and the heating element heats that liquid into an aerosol that the user inhales. And this aerosol contains nicotine, sometimes other substances like THC or CBD, flavorings, and other chemicals. So, if we were to compare the components of e cigarette aerosol with combustible cigarette smoke, the first thing to note is that combustible cigarette smoke contains around 7,000 chemicals, and at least 50 of those are carcinogenic. We have some of those chemicals on this slide. Whereas the e cigarette aerosol does contain harmful chemicals, but at much lower levels compared to what's found in combustible cigarette smoke. There's ultrafine particles. We're still studying them, but seeing similar impacts as cigarettes to cardiovascular and lung health. Each flavorant has its own chemical profile, many of which have been studied and found to be safe to ingest, but not rigorous studies found that they're safe to be inhaled. Volatile organic compounds, carcinogens like nitrosamines, and particularly in those pod mod systems where there's coils, we're finding that metals in the coils are leaching out into the liquid and being inhaled by the users. And then humectants like glycerol and propylene glycol that produce that large cloud are mild lung irritants.
So e-cigarettes do have fewer chemicals and at lower levels, but how much lower? A study conducted in about 5,000 people looked at the levels of chemicals that were absorbed systemically in users of different tobacco products. Along the left on the y-axis, you can see the urine concentration of a variety of biomarkers, and then those biomarkers are listed across the bottom of the slide on the x-axis along with their units of measurement. The navy bars represent smokers of traditional combustible cigarettes. The orange bars represent e-cigarette users, and the gold bars are a control representing non-users of tobacco products. Nicotine levels were 93% lower in e-cigarette users' urine compared to that of cigarette smokers' urine. However, this study was conducted with first-generation e-cigarette devices. Newer devices do deliver nicotine more efficiently. These other four chemicals are representatives of groups of compounds found in combustible cigarette smoke. So NNAL is a tobacco-specific nitrosamine, pyrene is a polycyclic aromatic hydrocarbon, acrylonitrile is a volatile organic compound, and cadmium is a heavy metal. Whew. All four of those are carcinogenic, and several have toxicity at additional organ systems as well. NNAL levels, as well as acrylonitrile levels, were decreased by more than 95% in the urine of e-cigarette users compared to traditional combustible cigarette smokers, and pyrene levels were decreased by 47%. cadmium levels were only 30% lower in e-cigarette users. Study authors did note that cadmium as a heavy metal has a half-life that's very long. It's measured in years in the human body. And almost all of the e-cigarette users in this study had been former cigarette smokers. So it is possible that the elevated cadmium levels are reflective not just of current e-cigarette use, but also of previous cigarette smoking. So since the e-cigarettes contain fewer chemicals and at lower levels, we might wonder what their risks are. So let's start with a comparison. Here's what we know about how traditional combustible cigarettes cause atherosclerotic cardiovascular disease. If we trace the pathogenesis, we see that smoking cigarettes causes endothelial dysfunction, which impacts the ability of blood vessels to relax and open up. This is one of the earliest manifestations of smoking-induced atherosclerosis. Smoking also causes chronic vascular wall inflammation, so inflammation in the walls of your blood vessels. This is the most important way that cigarette smoking contributes to the development and progression of atherosclerotic cardiovascular disease. Inflammation involves both local and systemic effects on the immune system. And then finally, smoking promotes thrombosis, so blood clot formation, through its effects on platelets, the coagulation cascade, and fibrinolysis. It also makes atherosclerotic plaques more vulnerable to rupture, in which case a heart attack occurs. Well, what about e-cigarettes? Some of the aerosol components of e-cigarettes have been shown to cause endothelial dysfunction and decrease nitric oxide availability, which would make blood vessels unable to relax and open up. That has been demonstrated both in vitro and in mice. Other components have been demonstrated to increase expression of inflammatory markers, both in vitro as well as in animal models. And finally, a survey of over 70,000 humans used the results of the National Health Interview Surveys of 2014 and 2016 to look at the cross-sectional association between daily e-cigarette use, daily cigarette smoking, and myocardial infarction or heart attack. And it found that e-cigarette use on a daily basis was associated with an odds ratio of 1.79 compared to non-use of tobacco products. Cigarette smoking, by comparison, was associated with an odds ratio of 2.72 compared to non-use. Besides increased risk of heart attacks or myocardial infarction, e-cigarettes also triggered indicators of increased COPD and lung cancer risk in animals. The increased risk of these respiratory diseases has also been demonstrated in human studies, with at least one respiratory study in humans showing no decreased risk from e-cigarettes versus traditional combustible cigarettes.
So, if we are going to understand the risk profile of e-cigarettes, we need to understand not only the harm, but also the potential benefits to adults who might be using them to quit combustible cigarette use. So these three bullet points are from the population assessment of tobacco and health study, and are exploring whether e-cigarettes are helping people to quit and maintain cessation. And from these results, we're seeing kind of a mixed bag, which is probably somewhat of an accurate depiction of what's happening right now, where young adults who are using e-cigarettes to quit smoking are having some success. We're seeing some former smokers who are using e-cigarettes. The nicotine is kind of reigniting their craving to smoke, and they're relapsing back to smoking, which isn't good. And then we're seeing youth use e-cigarettes, experiment with other tobacco products, and go on to uptake smoking. And we found that that was a trend happening regardless of the flavor of e-cigarettes they initiated with. So because of this mixed bag of results, the FDA, as well as the U.S. Preventive Health Services Task Force, have not approved e-cigarettes as a cessation device. We are also really interested in understanding the health impacts of dual use, which is vaping and smoking at the same time. And so we know that there are some harms that e-cigarettes can have to our lungs and heart. Smoking, that is well established. And so, what is the health impact of dual use? Some of the preliminary studies have found not only is there a higher dependence on nicotine because you're getting exposed to that from both products, but because of the cumulative exposure to toxicants from both products, it's resulting in poor health in general. Not surprisingly, to the lungs, asthma and COPD outcomes are worse, greater difficulty breathing. And just to note that we see the highest prevalence of dual use among our patients who have severe mental health conditions or substance use disorders. Is that true? Um, so just to kind of take a step back and show you how the products have evolved over time. Initially, they were actually targeted to adults, and the first generation products looked a lot like cigarettes. Over time, you've seen the devices are changing in shape, changing to look like other products like pens or tech devices. And something that I noticed was that as these e-cigarette manufacturers got bought out by tobacco companies, we saw a lot of the shape and design was uniquely, able to make it to be used in a way that could be concealed. So I'm like, who could that be thinking of in mind? Maybe high school students. We also saw the marketing of these products really target a young audience with sweet and trendy flavors. Basically, social media and its presence brought Juul to millions of young people. And we also saw an evolution of the nicotine, not only its chemical makeup, but also its concentration. So, free-base nicotine is what's found in cigarettes. It's harsh on the throat. It makes it difficult to actually kind of get over that harshness. But when they added a benzoic acid to the nicotine, it created a much smoother, much more powerful hit because you could take in a deeper breath or deeper inhalation of the nicotine, bringing more nicotine into your body. So, all of these fourth generation products have this nicotine salt solution, really accelerating experimentation to dependence, particularly among youth.
Since their introduction in the United States in 2007, the popularity of e-cigarettes has skyrocketed, especially among youths and young adults. This graph shows the results of the National Youth Tobacco Survey, an annual survey of high school and middle school students. Along the left, the y-axis shows the percentage of students who reported using e-cigarettes within the previous 30 days. And then the year is shown at the bottom of the slide on the x-axis. Prior to the COVID pandemic, over a fourth of high school students and over a tenth of middle schoolers reported using e-cigarettes. The methodology of the survey did change a little bit in 2022. So this isn't a perfect apples to apples comparison along the entirety of the timeline, but it does appear that use among young adults and students has decreased post-pandemic. In 2024, we also had new data for the first time. 2.4% of high school students and 1% of middle schoolers reported use of nicotine pouches.
So, what are nicotine pouches? Thought we would slide that into this section because they are a product that is gaining a lot of popularity in the last 5 years, particularly among young adults. So, this is synthetic nicotine, it's not plant derived. And these are, unlike tobacco chew or snus, these are spitless products. They're placed in between the lip and the gum, and nicotine is absorbed through the buccal mucosa. They come in a variety of flavors and strengths of nicotine. We're seeing about 1.8% of middle and high school students experimenting with these products. The majority of the interest is among adults, with about 16% of smokers interested in trying them, particularly if they had tried to quit with medication and counseling and were not successful. Why do we care about commercial tobacco product use among teens? Obviously, we don't want teens using any commercial tobacco product because of the chemical exposure and the impacts to heart and lungs. But there's also a concern about exposure to nicotine in the developing brain. And the former Surgeon General Vivek Murthy laid it out really clear. Compared with older adults, the brain of youth and young adults is more vulnerable to the negative consequences of nicotine exposure. So the brain's still developing up until the age of 25, 26. The effects of include addiction, priming for the use of other addictive substances, reduced impulse control, deficits in attention and cognition, and mood disorders, most likely a result of nicotine withdrawal, which if you become dependent, that's an experience you will encounter many times throughout the day if you don't have ready access to your tobacco product of choice. So for us to make a blanket statement of, risk for these non-combustible tobacco products is kind of difficult because there's so many factors we have to consider, like what product is being used, how it's being used, who is using it, whether it's a youth or an adult. And the regulatory environment really influences all of these. So some have been critical that the FDA hasn't tried to create enough of a balance of keeping the products on the market so that adults might have access to them while also protecting youth access, and making sure that they are not accessing these products and becoming dependent on them. So I'll round out this section by just, bringing it home to say that all commercial tobacco products can be viewed on a continuum of risk. We really want to target a lot of our interventions around helping people quit combustible tobacco products because that is the most lethal product. That is what's going to kill 1 out of every 2 people who continue to use that product across their lifespan. With smokeless tobacco, like chew, we're really swapping out risks to lung health with risks to oral health with an increase of 50-fold in oral cancer with that product. E-cigarettes, not combusted, but still has harmful chemicals someone's going to inhale. We don't have that longitudinal outlook, so we're cautiously looking at that product. It might be a product that helps people to quit smoking. We're still studying it. Nicotine pouches, not an approved cessation aid, but doesn't have harmful chemicals. Still need to learn more about its potential effects long term. Nicotine replacement therapy, FDA approved. Rachel's going to talk a little bit more about the FDA approved medications. And then again, the safest way to go is no use of any nicotine product, which as an end goal, that's really where we want to have our patients be ending up, to be completely free of their dependence on nicotine. So we are coming to our first learning assessment question. In studies comparing the health risks of e-cigarette and conventional cigarette use among adults, which of the following explains why e-cigarettes are less harmful than cigarettes? And we're just doing raise of hand. Okay. A, they contain no harmful substances whatsoever. B, they are proven to have no long-term health effects. C, they expose users to significantly fewer toxicants and carcinogens than combustible cigarettes. They are not associated with any risk of nicotine addiction. And if you raise your hand for C, you are correct.
So now we kind of look at how are we going to talk to the patients? There's a lot of information and things are constantly changing. I know just in my experience, I sat down with my middle schooler and high schooler. I have to think about that and just ask them, what do you guys know? And I took a general survey real quick that our community health system had for my kids, and they identified every single one of the e-cigarettes nicotine pouches correctly. And I was at 60%. So how do we talk to them and address them? So going back to pharmacy school, I pull back the 5 A's framework. So when we want to take a look at the patients and how we talk with them, we want to make sure that we're asking what tobacco use is. And as they pointed out, there's a lot of different forms. I know initially we thought of cigarettes. Now it's cigarettes, e-cigarettes, gum, chews, packets, all sorts of options for it. And then the advice to quit. But you also have to assess your willingness to quit. So we can always give that advice, but we have to make sure that there's that buy-in. And then the assist to quit is a really big aspect, but also able to motivate and not just show them a chart, but show them what it is the benefit of the future attempt if they need to get some time to kind of think about it and offer that further. And make sure to arrange the follow-up. One time is always great. We want to make sure that it's strong, clear, personalized, but then we also follow up showing that little bit of empathy that this isn't going to be a long-term or a short-term process. It's one that's going to be a marathon, and we'll be there to help. So we want to make sure to ask permission, because a lot of times you're talking to the patient in a lot of different ways. And you also want to make sure that you're identifying an appropriate time to talk about them. Sometimes it's really easy to say, hey, a new patient, do you smoke? Yes. Okay, we're going to come and drill home that you should stop smoking. But that may not be the right time. They may be coming to you for the first time for another problem. So you kind of have to make sure to identify, okay, this is something I can log in, build that relationship and rapport with the patient, see if they have interest, and then move on. We will also want to make sure to identify what kind of tobacco and what the quality is that they use. I know that a lot of times talking to patients, and as we did some internal assessments with some of the patients, a lot of times they thought of e-cigarettes as fine. Hey, you have a store on every corner. They must be healthy, right? It's just fine. There's no issue. So changing that perspective, but also to see what what it is that they actually use. If they use, their vape, well, how many cartridges do you use in a day? Well, I just have my one pen. Yeah, but you use 10 cartridges. What's your content? How much nicotine are you doing? Have you had any past quit attempts, or why did you start? Where did you come from? There's a lot of questions that have to be incorporated. But you want to make sure that you're not judging. I always say that, there's always those phrases that we want to make sure to understand where they're at. And that empathy is going to be the biggest step to go beyond just that first ask. So when you advise, you want to make sure you're clear, make sure you're very strong with what you're talking about, but also make it personalized to them. Couple quotes here. Quitting smoking is probably the single most important thing you can do to improve your health now and in the future. But it can be little things like quitting smoking can reduce the number of ear infections for your child. So you offer something that's going to let them see the entire picture of their health, but also that it's giving them something in return that they can see a benefit, something that they're going to want back. So it's not just, oh, well, you quit smoking, you're going to save money. No, it's being able to spend more time with your kids, not getting as exhausted when you take your grandkids to the playground, not being able to be tired and being able to actually walk to the corner store just to get that snack that you may want or something like that on a hot summer day. So then you need to also make sure and see, are they willing to take action? Are they confident in what they can do? If I help and provide resources, do they really feel like they're able to actually quit? And then are they ready? A lot of times we can offer all the information, but they may not be able to. And I know there's one that we always remember to be asked back in school and even early on, what is your quit date? And setting that really date can be very helpful for some people. And sometimes it can create a panic for another person. So this is really where you need to make sure to kind of assess the patient and customize it. So instead of saying like a quit date, hey, can we talk about this next month? Or, hey, we'll follow up in 3 months and we can just kind of see where you're at and see what you want to do. Give it a time, but allow them to kind of help make and warm up to that decision as well. And then key is to make sure that we're assisting, write the quit plan, give them something substantial that they can follow up with, but also remember that it's not just drugs that can help them, but it can be other things like the non-pharmacological options, which sometimes can even be just changing routines or finding something in place of it. I always think of my grandfather when he quit smoking. His doctor told me he needed to start walking. Well, he changed his life that every morning he would get up, read the paper, and have a smoke. Now, or I should say when he was quitting, he decided to get his newspaper not delivered to his house. He walked to the nearest newspaper box, which happened to be a Baskin Robbins, and he wrote and walked to Baskin Robbins every morning for 1.5 miles. He'd get a coffee and an ice cream, and then he'd walk back. He said there's 31 flavors, there's 31 days in most months, so a flavor a day. He quit smoking, still gained 15 pounds, but it was changing that routine that allowed him to have that success. And what was his buy-in? It was his grandkids, because my parents were a little hesitant to bring my sister and I, when we were younger, into their smoky house. So he wanted to see his grandkids. He quit smoking and ate a lot of ice cream. So arrange that follow-up. You want to make sure that if they do set a time, make sure it's quick and turn around. Don't just let them feel like they're hanging. So you want to make sure it's a quick date and then a quick follow-up and then a follow-up again. You want to make sure that you're utilizing phone calls. And if you can't do it, that you're looking at something like the quit line or other things to follow up so that they have a resource quickly and readily available. And then you also want to make sure that you're encouraging them. And I always say it's a marathon and it's okay to walk sometimes. And sometimes it's okay to sit down and sit on the curb and take a break as long as you keep going. We want to get to that finish line. And no matter how you get there, that's the end goal. And we're all looking forward to that. So it can take 6 months or it could take 6 weeks, but each person's individually different. So a lot of times, if you're unwilling or the patient doesn't move, we can assist the patient in thinking about what could happen in the future, letting them know you're always available and that you don't judge them for it. That's the biggest thing, because then they're more willing to come to you for future issues. And if they happen to get sick, get that pneumonia, cough, or something through the winter, and it's like, this is nagging, they keep getting that lung infection, then it gives us that opportunity to lead into the conversation again. So we apply it. Hard to take 5 A's into this back. So one thing we did in some of the studies and practice that we did was ask, advise, and refer. So we have 3 questions, and you want to focus on 3 key steps with that. So the one part is the refer incorporates your assess, assist, and arrange right off the bat. So we incorporate that into patient counseling and medication reviews quickly. We added customized talks to the patient. So you had to look at what their perception was. And a lot of times when we asked smoking, it was just cigarettes or e-cig or cigars. Very few actually thought of chewing tobacco or vaping. So they didn't think that was something that needed to quit in smoking cessation. Now, a lot of times people welcome the advice and they seem easy to discuss it, but when it came time to actually make a decision or to utilize the quit lines or cessation services, there was very low patient follow through. The biggest way that we made that change was actually where we included more information on what our ask was. We assisted them on making that first contact. So in the refer, we'd help dial the phone number for them. We would text the quit line. We'd enroll online. So we started holding the hand while they did it. And then we'd follow up in a couple days. Hey, did the quit line reach back out to you? Did the doctor follow up? So not only do they see us now as a partner, but we're actively engaged and we're checking in on them. We're showing we care. So the follow-up and the quitting of smoking increased, and it allowed us to have a better result. So we also need to make sure in the study that we utilized that Matthew put together when we put it in our community pharmacy was that all the pharmacists were trained in this. We wanted to review them. I know when I initially did his training, I looked back and I have to say that it was kind of one of those aha moments, because it was like, oh, well, I learned this training. I had 5 A's way back in pharmacy school, but now it's something that I actually do need to review and make sure that I'm hitting all these points, because no matter who you talk to, what age group, what ethnicity or culture, all of those need to be incorporated in order to get that buy-in from the patient. So he provided training when we put this study together to make sure that all the pharmacists knew the new tobacco, knew the new nicotine replacements, but also how to talk to patients with empathy and also how to navigate the referrals. One patient that we had really that struck me in the end was he had been referred to the quit line about 3 or 4 years ago, and he had no follow-up from them. And this time we actually helped him text. He got enrolled right off the bat with the consult. He had a follow-up within 48 hours. And when I called him 3 days later, he's like, oh, I already have my group assessment done and they have a referral for nicotine patches for me. So drastic difference, But even that follow-up, he was totally in buy-in. And I can say now we did this study, or when we did the study, it was back in April. He's still smoke-free now. So it's working, but you have to keep that follow-up. So which of the 5 statements regarding the 5 A's is not true? We have A, the framework provides a systematic way to screen and treat patients who use tobacco. B, should be brief, strong, and personally relevant. C, the 5 A's provide interventions to assist only those tobacco users who are willing to quit right now. And D, the first A is ask about tobacco use. C, correct.
So the great news is that we will have lots of opportunities to apply our 5 A's framework because over 2/3 of people who currently smoke cigarette do want to quit, and over half try each year. Unfortunately, fewer than a third who are trying to quit receive any counseling or medication to assist in their quit attempt. And without that, it's easy to understand why only about 3% of untreated smokers will achieve abstinence in any given year. On average, it takes about 6 quit attempts for somebody to achieve long-term tobacco abstinence. That's where we come in because there are evidence-based modalities available to help people increase their odds of success. We can think about 3 general approaches to tobacco cessation. At the population health level, we can think about raising the price of tobacco products through taxes, adopting comprehensive smoke-free policies, implementing public health campaigns using mass media, the use of product label warnings, particularly those with images, and requiring insurers to cover cessation services. These have all been demonstrated to increase tobacco cessation. We're typically more interested at the level of the individual, where both non-pharmacologic and pharmacotherapy options have been demonstrated to be cost-effective. Non-pharmacologic modalities include options like individual or group behavioral counseling, proactive quit counseling, and a variety of web-based or digital options. For example, text messaging services, especially if those services are interactive and go back and forth and are specifically tailored to an individual's responses. Allie will go into more detail on the non-pharmacologic modalities, and then I'll cover our pharmacotherapy options, which include varenicline, bupropion, and nicotine replacement therapy, or NRT. And while we'll discuss non-pharmacologic and pharmacotherapy options separately, they do work best in combination with one another. Which makes sense. When we think back to our 3-link chain of addiction, there are physical, psychological, and sociocultural factors impacting addiction in any one individual. Physical or biological factors tend to be most responsive to pharmacotherapy, while psychological and sociocultural factors are most responsive to non-pharmacologic modalities. In order to treat all 3 links in that chain of addiction, we need a variety of approaches.
Okay, so there are a couple different levels of intensity of behavioral counseling. Minimal intervention, which is where we're kind of linking patients up with some passive health education. And then there's a brief intervention, which is going to be what I'll touch on today, what you could cover in a counseling session around 3 minutes. And then intensive intervention. So the STAR method, which is for patients who are interested in making some change. So whether that may be reducing or quitting, we want to move patients to take action. And Brian touched on, having them think about a quit date in the near future, 2 weeks, 30 days. Encouraging them to tell other people that they are quitting and ask for their support. That is key to behavior change success. And then anticipating what challenges they might encounter, recalling past challenges if they've tried to quit in the past. What are some of their common triggers to use, and discuss some coping strategies to deal with those triggers. A common trigger is just having cues to smoke or used nicotine products in their house. So getting rid of all of those products. And then another key trigger is another person in the household that smokes. So encouraging them to kind of negotiate a smoke-free space, tobacco-free space. These are going to just be nuggets of counseling advice that will set them on the right path. So again, this is something that can take 3 minutes, and a lot of clinics just build it into their EMR. And the goal is, quitting is really, really challenging. The majority of people do have slips. Encourage them, if that happens, to just get right back on and recommit to quitting again. And view it as not a personal failure, whether they slipped or had a full blown relapse or they returned to regular tobacco use, but as an opportunity to learn what happened and take that into the future quit attempt. So that's really the goal of, counseling. But we know that many people have tried many times to quit with little success. And so there is the 5 R's method, which is really a guide for a conversation that explores why a patient might not be ready, what's keeping them stuck in their stage of ambivalence towards change. A lot of times it's just that lack of success in quitting. And so this can help you explore, have they used a medication in the past? How did they use it? I do have to note that sometimes poor adherence to a medication or not using it as directed does impact its efficacy. And that is impacting a person's ability to successfully quit. So this will allow you to explore all of that. The first R is what would be personally relevant. What would be a reason that is personally relevant to that person to quit again? What are some of the benefits of quitting? Risks? What might be the consequence of quitting? What are potential barriers to quitting? And then to repeat this and say, this is such an important part of your health and chronic disease management that next time I see you, I'm just going to ask, where you are in your readiness to quit again. And we can go from there. The 5 R's does really kind of come in to alignment with the principles of MI. So MI kind of views the patient as the expert on their own readiness to quit, on their past quit history, things they've done, on just challenges and where they're at right now. Whereas you're really the expert on how to help them when they're ready to quit and how to help them be successful. So just giving you a little bit of a primer into MI. And this is something I talk to a lot of clinician students about MI, that it's not just for those quote unquote difficult patients that don't want to change. It really benefits any patient interaction because it shows to them that this is a partnership, this is a dialogue. And so you can show that by asking open-ended questions of the patient. How are they thinking right now about quitting? Affirming their stance on it by saying, yeah, I know quitting is hard and it seems like you're not ready right now to make any changes. So reflecting and affirming and then summarizing what you hear just tells the patient you're on their side and you're not going to push them to do something they're not ready to do. So brief counseling intervention using the STAR method and then linking patients to more intensive counseling support through the quit line. This is a service I want you all to just keep in your back pocket because it is available to anyone in Wisconsin 13 years and older that uses any kind of commercial tobacco product. It's free. It's 24/7. Patients can get linked to it in a couple of different ways through the 1-800-QUIT-NOW number. There is a Spanish speaking only number underneath that. And they can also text in to enroll or go through the website. You as a pharmacist can also directly refer patients through a fax or e-referral, and that prompts a quitline coach to then proactively reach out to the patient. So it's not on them to make that first connection. Essentially, the services for adults are free coaching support, more intensive coaching, and then 2 weeks of nicotine replacement patches, gum, or lozenge. Youth 13 to 17 don't have access to the NRT, but they're getting access to that tailored youth specific coaching. online or through the text. And then I also wanted to draw your attention to Live Vape Free, which is the vaping cessation program for ages 13 to 26. We also have an American Indian program, which provides more intensive and culturally tailored support to those who self-identify as American Indian. So those are the Quitline services in a nutshell. And so the Wisconsin Tobacco Quitline offers 24/7 cessation support to residents 13 years and older who use any type of commercial tobacco product. What do you think? True, false? True. Yes. Okay.
All right. I get to move into the drugs. So we're going to move into talking about pharmacotherapy options for tobacco cessation. While there are only a few medications that are FDA approved for tobacco cessation, there is no shortage of clinical guidelines to tell us how best to use those medications. For the purposes of this presentation, I have focused on 4 documents. First, the report of the Surgeon General from 2020 on smoking cessation. That's a real quick 600 or 700 page read if you're looking for more information. Second, the guidelines from the United States Preventive Services Task Force. They have guidelines on tobacco cessation, first published in 1996 and most recently updated in 2021. A guideline from the American Thoracic Society that's specific to how to best initiate pharmacotherapy for adults. And finally, a clinical decision pathway from the American College of Cardiology. Our medications include varenicline, bupropion, and nicotine replacement therapy, or NRT. Varenicline is available in both 0.5 and 1 milligram tablets, as well as a starter kit that contains both strengths. Bupropion is available in immediate release, sustained release, and extended release formulations, but only the 150 milligram sustained release product has FDA approval for smoking cessation. Nicotine replacement therapy options include both long-acting nicotine transdermal patches, which we can think of as a controller medication that helps to decrease the frequency and intensity of nicotine withdrawal symptoms and cravings, as well as short-acting agents that include gum, lozenges, and the nasal spray. Any of those can be thought of as kind of reliever medications that we would use in response to more acute cravings. Many of us may have also been familiar with the nicotine inhaler, but sadly, its only manufacturer discontinued its sale in 2023. Since all of these medications work to decrease nicotine withdrawal symptoms as well as nicotine cravings, we might then ask, how much benefit does that convey to somebody trying to quit smoking? The EAGLE study is the largest clinical trial to date, offering head-to-head comparisons of the efficacy between the controller medications for tobacco cessation. This was a 24-week-long, randomized, double-blind, triple dummy study conducted in over 8,000 patients. Patients took the controller medication for the first 12 weeks of the study, and then they had follow-up for an additional 12 weeks. The primary endpoint of the study was continuous abstinence, which is shown at the left on the graph. And then the blue bars represent continuous abstinence during weeks 9 through 12. So the last 3 weeks that the patient was taking the controller medication. And then the secondary endpoint was continuous abstinence during weeks 9 through 24. So those last 3 weeks taking the medicine, as well as the 12 weeks of follow-up. In addition to pharmacotherapy, all of these patients also received 15 in-person counseling sessions to aid in their quit attempt. Varenicline was superior to all of the other options. Bupropion and the nicotine patch performed similarly to one another, and they were superior to placebo. Now we'll dive into each medication individually. For each medication, we'll talk about how it works, how to dose the medicine and adjust throughout the course of therapy. We'll go through counseling pearls to share with patients to optimize their odds of success, and we'll review patients for whom the medication requires special consideration. Varenicline acts as a partial agonist at the alpha-4 beta-2 nicotinic acetylcholine receptor. That's a receptor that's densely expressed in the mesolimbic system in the brain, in what we think of as the brain's reward pathway. When varenicline binds to that receptor, dopamine is released, but only at about 50% of the maximal effects compared to when nicotine binds to that receptor. So that's reducing withdrawal symptoms, it reduces cravings, and varenicline can also act to block nicotine from binding to that receptor to decrease the rewarding effects from ongoing tobacco use. This mechanism might make you think that pairing varenicline with an NRT option wouldn't be very helpful, because in theory that varenicline should block the nicotine from binding to the receptor, but there is some evidence that demonstrates improved efficacy when you partner varenicline with an NRT agent. This just demonstrates that both physical nicotine dependence as well as the behaviors associated with addiction and smoking are complex. They are not just limited to this one pathway and this one receptor. Throughout the presentation, I will decline to read specific doses or dose adjustments to you, but I do have them here so that they're available for your reference after the presentation. Varenicline dose should be titrated up over the first week of therapy, specifically to mitigate nausea associated with the medication. Additionally, varenicline is excreted over 90% unchanged in the urine, so it does require dose adjustment for people who have kidney dysfunction. Patients should be counseled to take varenicline with a full glass of water and with some food, again, to minimize nausea. And they should be counseled that that nausea typically does dissipate within the first couple weeks of therapy. In addition to nausea, insomnia or vivid dreams and headache are common side effects that insomnia also typically tolerates out after a couple of weeks. But if it persists, people can be counseled to take their second dose of the day around mid-afternoon. If that still isn't effective for alleviating sleep disturbances, the dose can be decreased to just once daily in the morning. There is efficacy data to support that reduced frequency. One special population to consider with varenicline is the elderly. Because older adults are more likely to have kidney dysfunction, it might be worthwhile to check a serum creatinine prior to initiating therapy in an older adult. Another population in which to consider varenicline is those who are not ready to quit. When varenicline was first approved, people were encouraged to start it and set a quit date at least 1 week later, but no more than 4 weeks later. Since then, studies have demonstrated that varenicline is effective in adults who didn't want to set a quit date initially, but who agreed to gradually decrease their smoking over 12 weeks. Similar rates of abstinence were achieved regardless of which approach patients took. And finally, we mentioned earlier that multiple patients will take several quit attempts before they achieve long-term abstinence. And varenicline has been demonstrated to be effective for retreatment. In a randomized clinical trial of patients who failed an initial course of varenicline at least 3 months in the past, a repeat 12-week course was associated with similar rates of abstinence as people taking it for the very first time. Bupropion was originally approved for depression in 1985 and for tobacco cessation in 1997. Its main mechanism is to inhibit reuptake of dopamine and norepinephrine, so that increases the level of those chemicals available in the brain. The increase in dopaminergic neurotransmission in particular is useful for tobacco cessation by decreasing withdrawal symptoms and cravings. Bupropion also seems to have some antagonist activity at that alpha-4 beta-2 nicotinic acetylcholine receptor, which might help decrease the rewarding effects of ongoing tobacco use. Again, this mechanism might make us think that adding nicotine replacement therapy with bupropion would have little utility. And while there is some data to support that combination, the data is less robust than that supporting the combination of varenicline with NRT. Bupropion dose should be titrated up over the first few days of therapy to minimize the risk of seizures. And bupropion is metabolized by your liver, and then those metabolites are eliminated through your kidneys in the urine. So it does require dose adjustment in both renal and hepatic dysfunction, and alternatives are preferable for people with severe kidney or liver disease. Bupropion is a moderate CYP2D6 inhibitor, so it decreases the metabolism of multiple medications. Reduced doses might be warranted for class 1C antiarrhythmics, the beta blocker metoprolol, multiple SSRI, SNRI, and tricyclic antidepressants, as well as a few antipsychotics. A key drug interaction to be aware of is between bupropion and tamoxifen. So tamoxifen is a prodrug. It's not active in its initial chemical form. It has to be metabolized or activated by CYP2D6 to work. So it may not work as well if it's taken with bupropion, and so this combination should be avoided. Bupropion itself might be less effective if taken with any of the broad spectrum CYP450 inducers listed here, and it should be avoided within 14 days of use of any MAOIs like racegiline or selegiline. Like any other sustained release medication, bupropion should be swallowed whole. Patients should be counseled not to crush it, not to chew it, not to split it. Because it is associated with insomnia, patients should be counseled that they should take their second dose of the day in early to mid-afternoon. If that is still ineffective for minimizing sleep disturbances, they can decrease to just once daily dosing. In that case, or in the case of comorbid depression, we might question the utility of extended release bupropion. While only the sustained release formulation has FDA approval for tobacco cessation, a study conducted at MD Anderson in about 650 patients who smoked and had cancer did directly compare the SR and XL formulations and found no difference in abstinence rates. Other common side effects include headache and dry mouth. Additionally, because bupropion is an antidepressant, it carries the same boxed warning as do other antidepressant medications regarding the risk of behavior changes, and because of its dopaminergic mechanism, it can be associated with inducing a manic state. Because of that, patients should be counseled that if they have any changes in their behavior or their mood, they should talk to their healthcare provider. Patients might also be interested that bupropion is indicated for weight loss when used in conjunction with naltrexone, and some people do lose weight when it's used on its own. And finally, bupropion is unsafe in overdose. Doses of just 600 to 900 milligrams, just a couple days of therapy, are associated with an increased risk of seizure and significant cardiac toxicity that mimics that of cocaine. So we always counsel patients to keep your medications out of the reach of children and pets, but particularly for bupropion, we want to encourage them to immediately seek medical attention if an accidental ingestion occurs, even of just a few tablets. Patients who are undergoing bariatric surgery might require an adjustment in bupropion from that sustained release to the immediate release formulation due to changes in absorption following surgery. And bupropion does lower the seizure threshold, so it is contraindicated in people who have a history of seizure disorder or who are predisposed to seizures. So that would include people with eating disorders, people who are prone to binge drinking, or who are abruptly discontinuing heavy alcohol use, benzodiazepine use, barbiturates, or anti-epileptic medications. Nicotine replacement therapy options predictably act as agonists at this nicotinic receptor. However, the nicotine from NRT products is absorbed more slowly and reaches lower peak levels than the nicotine from combustible cigarettes. So this helps to reduce nicotine cravings and withdrawal symptoms. It also helps to block the pleasurable rewarding effects experienced when smoking tobacco products. All of the nicotine replacement therapy products have similar efficacy if used as monotherapy, but their efficacy is enhanced by pairing a long-acting with a short-acting formulation. Use of that combination of NRT products is thought to have efficacy similar to that of varenicline. Nicotine patches are dosed based on level of tobacco dependence, with those smoking 10 or more cigarettes per day starting on the 21 milligram per 24-hour patch strength. The 14 milligram strength should be used for those who smoke fewer cigarettes per day. There is no evidence of improved efficacy by using higher strengths, for example, by putting two 21 milligram patches on a person at the same time. And while patches are typically marketed as tapering doses, there's no evidence that tapering improves cessation rates, so it is optional. If you do choose to taper nicotine patch dose, you should stay at the initial dose for at least 6 weeks before decreasing. Patches should be applied to upper back, arm, or chest and rotated daily so that we don't repeat the same site of application for at least 1 week to minimize the risk of skin irritation. And nicotine patches can be begun before a quit date. There is evidence of increased efficacy with preloading by up to 2 to 4 weeks. I mentioned skin irritation. Insomnia or vivid dreams can also be common adverse effects from nicotine patches. Nicotine gum and lozenges are dosed instead of on the number of cigarettes per day based on the time of day to the first cigarette after a person wakes up. If a person can go for more than 30 minutes after awakening, then we suggest that they start with 2 milligram gum or lozenges. If that time frame is 30 minutes or less, we suggest they start at a dose of 4 milligrams. Like the patches, there's no requirement to taper the dose of nicotine gum or lozenges. If tapering, rather than changing the dose, the suggestion is to extend the interval after at least 6 weeks at the initial interval. You can consider decreasing the dose if pairing the gum or the lozenge with the patch, but that recommendation is not consistent between all of the treatment guidelines. Gum or lozenges should be used every 1 or 1 to 2 hours. And while our instructions typically emphasize the maximum number of doses a person can use in a day, we want to make sure that we're counseling patients to use these medications enough, at least 9 times a day early on in therapy for efficacy. Nicotine gum can be associated with jaw soreness, and both are associated with mouth irritation, hiccups, and GI side effects. Unlike the other nicotine replacement products, nicotine nasal spray is only available as a prescription item. It comes with 200 sprays per bottle, and it has the fastest onset of any of the short-acting nicotine products, with peak plasma levels seen in about 10 minutes after administration. Similar to the other agents, it does not have any requirement for tapering the dose, but if tapering rather than changing the actual dose, we would suggest that people extend their interval after 4 to 6 weeks. They can use 1 spray in each nostril 1 or 2 times per hour, up to about 80 sprays per day, initially using at least 16 sprays per day. Unfortunately, nicotine nasal spray is the most difficult of any of the nicotine replacement products for tolerability. The nasal and throat irritation in particular really limit the usefulness of this formulation. When we're counseling patients, if they are struggling with sleep disturbances from nicotine patches, we can counsel them that they can take it off at bedtime if they so choose. Patches can be worn in the bath, shower, or swimming pool, but they should be removed before vigorous extended exercise or hot tub use. When we're counseling patients about nicotine gum, we want to make sure that we mention the chew and park technique. This is not meant to be chewed the way other gums are chewed. Instead, patients just chew the gum slowly until they get a distinct taste or tingling sensation. Then they place the gum and park it between their cheek and their gum tissue until that taste or sensation disappears. They can repeat that process of chew, park, for about 30 minutes until the taste and sensation don't recur upon chewing. After that, the gum can be discarded. Nicotine lozenges are likewise not meant to be chewed or sucked or swallowed. They also get parked between the gum and the cheek tissue, and they are allowed to melt slowly. It is important for both the gum and the lozenges that people avoid food and drinks for some time beforehand. The nicotine in these formulations is alkaline, and it needs to stay alkaline in order to be absorbed. So particularly acidic beverages like coffee or soda are problematic before having gum or lozenges. So for our patients who have a need for morning nicotine and morning caffeine, a good suggestion is to have a piece of gum or lozenge first and then have their morning coffee afterwards. If people disregard our directions and they do chew the nicotine gum continuously, or they chew and suck on a lozenge quickly, the nicotine gets released too quickly. Ideally, we want it to be absorbed across the oral mucosa. If it's released too quickly, people tend to swallow it, and that's what causes the GI side effects that can be seen with these products. The nasal spray is meant to be absorbed across the nasal mucosa. So again, we don't want people to sniff, swallow, or inhale when they're spraying it, and they should wait a couple minutes after use before blowing their nose for best benefit. Nicotine patches should be avoided in patients with skin conditions like psoriasis, eczema, or atopic dermatitis, as those patients are more likely to have really significant skin irritation. For patients with poor dental work or poor dentition, extensive dental work, or dentures, we would recommend lozenges over nicotine gum, which can be damaging to dental work. And I mentioned that nasal and throat irritation associated with the nasal spray really limit its usefulness in the general population, and they make it a particularly poor choice for patients who have chronic rhinitis, nasal polyps, or severe reactive airway disease. Once pharmacotherapy is initiated, the minimum duration of therapy for any of the cessation medications is 12 weeks, and varenicline is specifically FDA approved for 6 months of therapy. The optimal duration of therapy has not yet been established, but the treatment guidelines do recommend extending beyond 12 weeks, with some sources recommending 12 or 18 months of therapy. To summarize our treatment approach, every tobacco user should receive non-pharmacologic therapy to assist in quitting. Additionally, most adults, with few exceptions, should receive pharmacotherapy. Varenicline is the most effective of the controller medications when used as monotherapy, but combination NRT yields similar efficacy. Either is reasonable as initial therapy. You can consider starting varenicline or nicotine replacement therapy prior to a planned quit date. If a patient is unable to take varenicline or combination NRT, then either bupropion or single NRT are options. Combination therapy does have some promising efficacy data, but we also want to balance that against the risk of adverse effects that would accompany an additional agent. Next, we'll look at people trying to quit smoking with common comorbidities, cardiovascular disease, or mental illness. The American College of Cardiology addresses tobacco cessation and cardiovascular disease. Let's first focus on that top line. For our purposes, cardiovascular disease in these guidelines was not just atherosclerotic cardiovascular disease, but also includes valvular heart disease, heart failure, and arrhythmia. For outpatients with stable cardiovascular disease, the recommendations very closely mirror those of our general treatment pathway. The only exception is that there's this third line option for nortriptyline. So the American College of Cardiology says that you can use nortriptyline, and then they caution it's not FDA approved for tobacco cessation. It has known QT prolonging effects. It is unsafe in overdose, and it's poorly studied in patients with cardiovascular disease. So for my money, I would skip the nortriptyline and move to combination therapy that does have safety and efficacy data over nortriptyline, which kind of lacks evidence in either of those areas. For patients who are hospitalized with acute coronary syndrome, the American College of Cardiology recommends either a nicotine patch with or without a short-acting adjunct or varenicline. Any of these can be started in the hospital during an acute coronary syndrome. However, some committee members said they would advocate for waiting until discharge, citing tolerability concerns, which is reasonable to me. If we think about our patients being hospitalized with acute coronary syndrome, they are often starting multiple new medications during that hospital stay. So in terms of avoiding adverse effects and in avoiding confusion, I would advocate for waiting until discharge to start a medication like varenicline, even if you are able to start a nicotine patch during hospitalization. Second line is single NRT. Third line is bupropion. And then combination therapy is not addressed because that would typically not be managed during a hospitalization for acute coronary syndrome, but rather managed on an outpatient basis for somebody unable to quit with a single agent. Patients with mental health diagnoses bear a disproportional burden of tobacco dependence, with rates of tobacco use that are much higher than those seen in the general population. Patients with more severe mental illness have the greatest risk of comorbid tobacco dependence. Patients with mental health diagnoses also bear a disproportional burden in terms of barriers to successfully quitting. They've historically been poorly represented in clinical trials. They're less likely to be linked to appropriate non-pharmacologic therapy or pharmacotherapy, and they're less likely to be advised to quit. This is despite an abundance of evidence that tobacco cessation improves psychological outcomes for patients with mental health disorders. This has been shown for a wide variety of diagnoses, including mood disorders, anxiety disorders, and substance use disorders. Part of the problem is that tobacco cessation medications have had a really messy history in patients with mental health diagnoses. Varenicline was FDA approved in 2006, and shortly thereafter, case reports surfaced of depression, psychosis, and even suicide. The FDA conducted safety reviews and in 2009 opted to require a black box warning on both varenicline and bupropion regarding the risk of serious neuropsychiatric adverse effects, including changes in behavior, depressed mood, suicidal ideation, or attempted suicide. Multiple observational studies, a cohort study of over 80,000 patients, and a meta-analysis of 39 randomized controlled trials demonstrated safety, but it wasn't until the EAGLE study was published that the FDA finally removed that black box warning from varenicline, and the bupropion label was updated. It still contains the same black box warning that is found on all antidepressant medications, but the language specific to neuropsychiatric adverse effects for smoking cessation was removed. We had discussed the EAGLE study earlier in the presentation since it provided great head-to-head comparison regarding efficacy of the controller medicines for tobacco cessation, but it's also a pivotal study for safety of the controller medications for tobacco cessation. The primary safety endpoint of the study was a composite neuropsychiatric adverse events that included components of anxiety, depression, agitation, aggression, delusions, hallucinations, paranoia, mania, suicidal ideation, suicidal behavior, or suicidal completion. And there was no difference between any of these treatment groups in the prevalence of that composite endpoint. This held true even when we looked at the cohort of patients in that study who had pre-existing psychiatric diagnoses. There was no difference between groups in the frequency of neuropsychiatric adverse events. Beyond varenicline, bupropion, and nicotine replacement therapy, there are several medications with new or emerging data to support their use for tobacco cessation. Cytisinicline, or cytisine, is used in several European countries for tobacco cessation, including cessation of combustible cigarettes as well as e-cigarette use. It's mechanistically very similar to varenicline and has been recently studied in the United States in 2 randomized clinical trials, one conducted in 810 daily cigarette smokers and one in 160 daily e-cigarette users. In both studies, patients received either cytisinicline or a placebo 3 times daily for 12 weeks, and then they had follow-up extending after that period. The primary outcome was biochemically verified continuous smoking abstinence. And in the cigarette smokers, there was a demonstrated increase in that abstinence both during the last 4 weeks on the therapy as well as during the extended follow-up period. in the study of e-cigarette users, there was statistically an increase in abstinence while the patients were on the therapy, but that statistical significance was lost during the extended follow-up. Of course, this was a much smaller study than was the study of cigarette users, so a larger study would be useful for answering the question of whether or not cytisinicline might have a place for e-cigarette users. Also of interest in this study, there was a very high rate of abstinence achieved in the placebo group. So in all of the pharmacotherapy studies of tobacco cessation agents, people also receive non-pharmacological assistance, like behavioral counseling. The very high rate of abstinence achieved in the placebo group in this study is, to me, hypothesis generating. It would be interesting to see if additional studies would demonstrate that non-pharmacologic modalities are consistently more useful for e-cigarette users. The glucagon-like peptide 1 receptor agonists are also a class of medication with emerging data to support efficacy for nicotine use disorder. Exenatide, liraglutide, dulaglutide, and semaglutide have all been studied, and there are multiple ongoing studies with these agents for cessation. For our technician friends in the audience, these are the really expensive medications that we keep in the fridge and usually use for diabetes and try to get covered for weight loss. They do show evidence in both animal and human studies that they seem to reduce the rewarding and reinforcing effects of nicotine, and they also decrease weight gain related to cessation. They also seem to have some benefit with regard to decreasing the cognitive deficits and adverse effects on mood that can occur during tobacco cessation. And there's hope that because we know they decrease cardiovascular risk in patients taking them for diabetes, that they may also help to offset some of the cardiovascular toxicity from tobacco use. We do have quite a lot of unanswered questions, though, remaining regarding our GLP-1s. They have mainly been studied in patients who have comorbid diabetes, prediabetes, or obesity, so their efficacy in the general patient population is not well understood. Additionally, we're not sure about what the right dose or duration of therapy would be if we use them purely for nicotine cessation. They've typically been studied at doses that would be highly impractical to dispense using our available products. There's no way to give part of a dose of some of these medications, and we don't like to break up boxes of them. Additionally, they've been studied on the order of weeks, so we don't know about their usefulness in an extended time frame. There are multiple studies ongoing, so it will be exciting to see where they do land, but they're a little bit premature for use just yet. That brings us to our learning assessment. Which counseling points should we share with a patient starting nicotine replacement therapy? Place nicotine patches anywhere you want on your body. Chew nicotine gum until a distinct taste or tingling sensation occurs, and then park it between your cheek and gums. Chew nicotine gum continuously until it loses its flavor. Or chew nicotine lozenges to best release the nicotine when you need it for significant cravings. What do you guys think? B, oh, you're so smart. All right, then Allie will discuss how we can be paid.
Thank you. I think that was probably the most comprehensive review of the pharmacologic options that I have ever heard. So thank you so much, Rachel, for that. I have a few remaining comments in this objective. But before I get into them, I just want to preface that I am not an expert on billing. So I'll be referring to the Pharmacy Society of Wisconsin's billing guide at the end. If you have more in-depth questions, also to their team. So smoking cessation is a covered service under Medicaid, and those services that are covered include tobacco cessation counseling that is delivered one-on-one or face-to-face. So unfortunately at this time, I don't believe group sessions are covered or telephone or web-based services for tobacco cessation counseling. These are the medications that are covered under Medicaid. even over-the-counter products. And in forward, they're called legend products. So you can write a prescription for over-the-counter nicotine replacement therapies. That prescription requires a diagnosis code. There are a few ways you can bill for tobacco cessation services. So the most common are the time-based CPT codes for tobacco cessation counseling. The 99406 is for 3 minutes up to 10. 99407 is greater than 10. And just a reminder that any billing claim has to include that diagnosis code. So that ICD-9 code or ICD-10 for tobacco cessation counseling. In my consultation with the Pharmacy Society of Wisconsin, they also wanted to highlight that there are additional ways to bill. Those preventive evaluation and management codes or office visit codes can also be used and do carry a higher reimbursement rate for tobacco cessation counseling. So reimbursement is made as a percentage of the physician's payment, and payment will be made at lesser of the usual and customary charge or no more than 90% of the physician fee for that procedure. So you have to include documentation to support that those services are medically necessary for tobacco cessation. This can include some of the items on this slide that you can review reference afterwards, but basically we want to support not just that counseling was provided, but what was said. So methods or skills you talked about to support cessation. If you counseled around a medication for cessation, if the patient set a quit date, if you made a referral to the quit line or provided resources to the patient, all of that to support the claim is appropriate. I also wanted to highlight technicians' role in tobacco cessation, and especially in just letting the patient know that this is a service that is provided. So when you are, registering a new patient, asking about their tobacco use, connecting them to the pharmacist for counseling, or referring them to the quit line, preparing the claim, all of those are roles the technician can play. And so it's really the pharmacist and the technician working together as a team to make sure that cessation services are a viable service in a busy pharmacy setting. These are the resources I really wanted to highlight because they go into more depth on not only pharmacists as a Medicaid eligible provider, but how you can specifically bill for cessation. Forward Health has some great resources. The First Pharmacy Society of Wisconsin's Billing Resource Guide. Forward Health made a provider enrollment training that is a video, and then ALA has a billing guide specifically for tobacco screening and cessation. So we have made it to our last learning assessment question, which is, in which of the following ways can pharmacists be reimbursed by Wisconsin Medicaid for providing tobacco cessation services? We have those office visit codes, preventive E&M codes, the time-based CPT codes, or all of the above? Yes, all of the above. So we have made it to the end, and I'm going to give you the code, and those assessment questions we just reviewed will be on the post-session quiz. So you're prepared well for them. I think I need to show you one more. Oh, no, that was all, the last one. All right, thank you.